We're going to start the webinar just in a few minutes, so hold tight and we'll be right back with you. Hello everyone, welcome to an exclusive webinar here with Judit Marin. Judit, can you hear me just to make sure?
Yes, I can. Can you hear me?
Yes, great, okay, awesome. So Judit is here with us. She's here from NCTA and she's also a seasoned Spanish interpreter and translator. She's going to be speaking to us about pain management, interpreting for pain management patients. So some sort of new trends and treatments. A very unique and important topic for a lot of medical interpreters out there. So Judy, thank you so much for being with us, and I'll have you share your screen and get going. Thank you.
All right, thank you. Can you see my screen? Okay.
Yes, perfect.
Okay, perfect. Thank you. So thank you, Caroline and Buslingo, for inviting me to present this webinar. I believe this is my third time presenting in collaboration with Buslingo, and every time Caroline asks me to present one of these, it's hard to say no. So welcome everyone, and thank you all for listening. And now, or maybe in a later time, I know that we all have busy lives and schedules, so I really appreciate that you're taking time to listen to this topic. And before we start, I just want to say a couple of brief things about what I do as an interpreter and translator as well. So let me see. Okay, here we go. So just a couple of things so you know a little bit of what I do. I've been freelancing as a healthcare interpreter for almost 20 years now. I became certified by the state of California almost 20 years ago. A long time ago, we didn't have a national certification for medical interpreters like we have now. So your only option, and we were lucky in California, was to take a state exam, which I did. And I also became certified almost 20 years ago as a ATA certified English into Spanish translator. And I'm currently serving as NCTA Vice President. NCTA is the Northern California Translators Association, which is the local chapter here in Northern California of the American Translators Association. I also serve as the Continuing Education Chair. I provide all the workshops and I coordinate all the continuing education for members and non-members. It's something that I really love to do. And for the past 15 years, I've been training medical interpreters, which is also something that I really enjoy very much. So I like to start by showing you something that I'm sure you've seen if you've interpreted at pain management, which is the famous pain measurement scale. And I like to do a little bit of an interpreting exercise from the comfort of your home or office, wherever you are. And hopefully you'll hear some audios of different ways providers and doctors ask patients about the intensity of their pain. And then keep that in your mind. And in a few slides, I'll go over this pain scale. All right, so hopefully, let's see if we can hear the audio. Okay, so here you had four examples of different ways that providers can ask patients about the intensity of the pain. And I'm sure you've heard all kinds of versions of this. And for me, the problem is not as much that it's difficult to interpret what the providers or doctors say. The difficulty is, do the patients really understand the pain scale? Do the patients know what a 3 or 4 means, or what a 9 or 10 means? Do doctors take the time to explain in detail what these numbers mean? And what happens when the doctor, like in this last example, says, "Oh, interpreter, I need to step outside, go and get some things, or take a phone call. I'll be right back. In the meantime, why don't you ask the patient about his or her level of pain?" So, what happens when? What do you do? I mean, what I do is that I step outside of the room as well, and I tell the doctor I'll be happy to interpret the pain scale when you come back, but I never stay in the room with a patient by myself once the appointment starts, while the doctor is gone, and asking the patient questions. I don't think that's the right way to do things. And it has all kinds of problems and ethical problems and liability. So, but that happens. We are exposed to that. So hold your thoughts on this. I'll introduce a little bit of what pain management is, and then we'll talk about these challenges that we face when we interpret in this medical specialty. And I just collected a few things that have been challenging for me, and I'll share them with you, and hopefully they'll be useful. So just a little bit of history about what pain management is. And pain management has been around forever, of course, but pain management in the sense that I understand it, you may understand it when you go and interpret, or when you interpret over the phone or on video. In the modern sense, it's a trend that started in the 1990s, where some doctors believe that some patients who suffer from moderate to severe chronic pain had been ignored, and these patients were suffering unnecessarily. They didn't get the right treatment. That's where the concept of pain management in the modern sense started. And some doctors ask if pain should be the fifth vital sign when patients go to the doctor and they get their vital signs. There's four main vital signs: blood pressure, temperature, pulse, breathing rate. And some doctors believe that we should ask all patients if they are in pain. And maybe if you've been a patient, I noticed that when I've been to the doctor recently, well, they take my blood pressure, they're asking me if I'm in pain. But the purpose of my appointment was not anything to do with pain. So I noticed that in some places they already do that. So what's pain management? Pain management is three things. It's the diagnosis and treatment of chronic pain. So we're talking about people with chronic, from moderate to severe chronic pain. The idea of pain management, of course, is to reduce pain so the patient's daily function is maximized and the patient can be more active. Pain management is usually what we call an interdisciplinary medical specialty. When you go to a pain management clinic, you'll see doctors, psychologists, psychiatrists, physical therapists, acupuncturists, massage therapists, so all kinds of providers there. So you might be interpreting for different kinds of providers. So a good idea when you are given this kind of appointment is to ask who's the appointment with. It's with the providers, with the doctor's assistant, it's with the acupuncturist, it's with the psychiatrist, because the appointment will be different. Um, and also pain management, it has a very important educational aspect to it, where if it's done well, patients are educated on different treatment options so they can choose the option that they would like to pursue. So the pain management is offered to patients in end-of-life, cancer care, palliative care situations, also for people who suffer industrial and personal injuries, car accidents, sport injuries, again, for chronic, moderate to severe pain. Most of my presentation will focus on the industrial and personal injuries aspect of it because that's where I have more experience. I've done some cancer care, but my experience there is limited. It was with pediatrics, and it was not as much pain management, but regular cancer care treatment. But I'm very much familiar with the industrial and personal injuries aspect of pain management. And this is what I'm going to focus on. But I think you can apply it to other subspecialties or different kinds of patients that you may help. So I'll focus on, in terms of things that are relevant for us as interpreters, I'll focus on three aspects: the intensity and description of the pain, treatments that I offer, and new trends that I've seen in the last, would say, couple of years, and perhaps you've seen as well. So I'm going back to that pain scale, and for you and for me, I think, again, it's not difficult to interpret when the doctor says, on a scale from 0 to 10, how would you describe your average pain? That's not particularly hard to interpret. But the question is, do doctors explain the meaning of all the numbers of the pain scale? And I would say that 9 out of 10 doctors don't bother to explain the meaning of the numbers. And if they do, they'll just say that 9 or 10 is like, going to the emergency room or having a baby, or like in the example that we heard, being shot, stabbed. I have a doctor who always asks the question that way, from 0 to 10, and 10 is being shot or stabbed, putting the hand in the fire. So I think that's kind of funny, but it's a nice way. But what's a 4? What's a 5? What's a 6? Do any doctors explain that to the patients? And to me, my experience is that most doctors don't. And here's another question for you. Should interpreters explain the meaning of the pain scale? For instance, when you're filling out forms, you may be at the pain clinic and you're filling out forms, and the question comes up from 0 to 10, and maybe that question is asked several times for different body parts, etc. Should we explain those numbers? And my answer, and what I do, is that I don't explain the numbers for many reasons, because maybe I'm not right. Maybe my idea of the pain scale is different from what the doctor idea of pain scale. I heard good descriptions, but I just ask the question and I let the patient answer, and I just record what the patient tells me. I really don't explain the meaning of the numbers. If a patient asks me, for instance, here's an example. You're filling out forms and you're asking from 0 to 10, and the patient states for all the pain scale questions that his or her pain is 10 out of 10 all the time. So if they tell me that, that's what I record. That's what I write down. I don't debate with them. I don't tell them 10 is going to the emergency room. I really don't know. That person might be experiencing a 10 pain, maybe not at that particular moment, but I really don't. So I just write down what the patient tells me, And I believe, hopefully, that the doctor will explain and review those answers and will explain or ask any questions if the doctor thinks is relevant. And also, before we move forward, sometimes patients may ask you, it says, well, I don't know, what's a 6? What's a 9? And if they do that, what I tell them is like, look, I'm not particularly sure, but I will be more than happy to interpret that question. You can ask that question to the doctor when we go inside the room, and I will be more than happy to interpret that. And so I always make an effort to delegate and to ask the patients, tell the patients, I'm here to help you. And please ask that question to the provider, and I'm here to interpret that. But I really don't answer the question about what the pain scale means. As you already know, there's dozens and dozens of words to describe the pain in more detail in English. Perhaps that's more limited in other languages, certainly is in Spanish, and I'm sure it is in other languages. So that's another challenge for us. For instance, I go to interpret in pain management clinics where the forms only have maybe 6 or 7 pain description words, whereas other forms or questionnaires have 20 words. So my question for you is, let's say you're filling out a form, and then, uh, could you describe the quality of your pain? And then there's all these words. And what should you do? Should you A, read all the pain words, B, read only the most common ones like dull, sharp, burning, throbbing, etc.? Or should you just don't read any of the words and ask patients to describe their pain without reading any words? And so think about it for a second. Would you read all the pain words in the questionnaire? Would you read only the most common ones? Or would you ask the patients to describe it without you reading any words? What I do is that I read all the words. If there are a lot of words, by the time I'm down the list halfway, the patients already start telling me the words that describe their pain. So usually, it's been rare that if there's 20 words there, that I translate or interpret most of them. And also, during the visit, pay attention to the most commonly used words by providers. And after almost 20 years of interpreting, I reduce it to basically 6 or 7 words, which are the words you see here on the screen. When the doctors ask patients about the quality of their pain, usually use these words here, sharp or dull, burning or throbbing, aching or pins and needles. So definitely you should know how to interpret those in your language of service. And of course, if you know more, that's great, and you should. But definitely you should know these for me are the main ones and in fact, my experience is that when you ask about the quality or aspect of the pain or to describe it in more detail, a lot of patients just say, I just have pain. And they have a hard time describing it because it's just part of a cultural thing, and I'm not sure, and it's a language thing. Perhaps we don't have as many words to describe it. And also, a lot of times, especially when you interpret for injured workers, patients are frustrated and they have to wait a long time to get a visit, and they just want to get the message across that they're in pain, and that's all they care to say, and they just want to be heard. And it's hard sometimes to drill down the idea of could you describe in more detail. But if you give them these 5, 6 words, patients will tell you in more detail what type of pain is. And this is important. These words are important because they help the doctor to narrow down the type of pain that this person has. Another very important aspect of pain that I think is often overlooked is the location of the pain. Is it a very localized pain in one particular place, or it's what we call a more diffuse pain? For instance, let's say that you're interpreting for an orthopedic surgeon and the doctor says, "What do you have pain?" And the patient says, "Oh, I have pain all over here." And he might be pointing to his entire arm, the entire arm. And that might be true. The patient has pain in the entire arm. But sometimes, especially when you interpret at consults with surgeons where the doctor will decide if he should operate on this person or not. In general, surgeons don't like diffuse pain. They don't like it very much when the patient says, "I have pain all over here, my arm," because they need to see the specific location of the pain. They will not operate on an entire arm. They will operate on a shoulder or elbow or the wrist. So, and what happens, I noticed, perhaps you've noticed this too, that when a patient who's been injured at work, for instance, finally gets an appointment with a surgeon for a consult, and they've been waiting for maybe weeks or months for that appointment. They really want to convey that idea that they're in pain, and that's why probably they, point to several parts of their bodies. And I heard doctors saying, "Oh, but can you please point with one finger where the pain is?" And even then, patients go and says, "Well, here and over here." And then I think doctors get frustrated, and doctors say directly to the patient, "I cannot operate on your entire arm or leg. You have to pinpoint a location, otherwise I will not operate." So it's very important when you interpret and the doctor asks about the location of the pain. It's super important to convey that idea of the specific point where the pain is. It could be that the patient has pain in the entire arm because it's nerve pain, and that's what you're going to say. But please pay attention to the difference between localized pain and diffuse pain. So when we talk about treatments for pain management, we have three main categories: what we call conservative pain, minimally invasive treatment, or invasive treatment. So conservative treatment is any treatment that does not involve a surgery. So that would be therapy, medications, etc. Minimally invasive would be injections, for instance, and invasive is surgery. So for pain management, we'll talk about conservative treatment and minimally invasive treatments. So conservative treatment, like I said, is any treatment that doesn't involve surgery. So in this category, you will find medications, physical therapy, chiropractor treatment, water therapy, acupuncture, and all the studies. Sometimes, I don't know if it happens to you, but sometimes the doctor says, "Oh, Mr. Garcia, did you receive any treatment for this injury?" And the patient says, "No, they didn't do anything to me." And the doctor says, "Well, yeah, you got an MRI done." And for the patient, an MRI is not treatment, it's a study. But doctors consider all studies part of treatment. Conservative treatment also includes a home exercise program that a patient, after they complete physical therapy, they're given a set of exercises that people do at home on their own. Ice heat or a TENS unit. Sometimes these TENS units are used mainly in physical therapy sessions, but some patients are lucky enough to get this machine being sent to their houses, and they can use the machine whenever they need it. Uh, New trends in conservative treatment are virtual reality, biofeedback, and MLS laser therapy. And I've never interpreted at a virtual reality appointment, but I've been to clinics where they offer that service, and I see it announced in their marketing materials or posters or brochure. So let's see, I'm going to try to show you a video. It's just 2 minutes about how virtual reality can help people with chronic to severe pain. So let's see if I can bring this video up and you guys can see and hear it. All right, so I think this is really exciting. And again, I have not interpreted at a virtual reality appointment, but I definitely seen it announced out there in the clinic. So this might be the future of pain management. So I think this is really exciting. And another thing that you've probably been seeing in pain management clinics, it's what's called biofeedback. It's also used by in mental health settings as well. It's a relaxation technique where real-time physiological info is displayed to a patient through a monitor. So patients are hooked up to this monitor like an iPad thing, and they have like a blood pressure cuff, and basically it's a technique where they learn to relax and breathing techniques so they can see if their blood pressure is up or down, etc. And also another thing I've seen in some of the clinics I interpret in pain management is this machine. It's called an MLS laser therapy, and basically it's laser treatment that creates energy that painlessly penetrates into tissue cells and accelerates the natural healing process. See here that some of these techniques are non-pharmacological. It's basically painless. Basically, it's a way, or the virtual reality is a way to trick your brain to treat pain management, or different techniques that are more natural and staying away from medication. And so since we're talking about medication, medication is still a big part of pain management, of course. Here's a list of the main categories of pain medication, or medication in general, excuse me, that patients can be prescribed. And I want you to pay attention to this list. We have non-steroidal anti-inflammatory drugs, opioids, muscle relaxants, sleep aids, stomach protection, medication for the effects of the other medications that patients are given, anti-anxiety, antidepressants, and nerve pain. Nowadays, I would say in the last couple of years, opioids and sleeping aids have been dropped from this list, and it's very rare for patients to be prescribed these medications. Again, I'm not, obviously, if you're interpreting in palliative care, end of life cancer care, it's a different story. I'm talking about injured workers, personal injuries. Opioids and sleeping aids are not there anymore. People are basically given ibuprofen 600 or 800, And if the pain is more severe, they might be getting Norco or tramadol in very low dosage. Again, patients used to receive antidepressants and anti-anxiety medications. I remember for many years, patients would be prescribed an antidepressant called Cymbalta, which was what I heard, a great medication that not only was good as an antidepressant, but also helped with pain. It's been, for the past 3-4 years, I haven't heard any patient being prescribed these kinds of medications. Again, because there's been quote unquote like a crackdown on overprescribing medication in pain management. And this is important because this is due to a problem we have in this country that's called the opioid epidemic. If you have read papers or listened to the radio or TV news, you probably have heard about the opioid epidemic. And it's important that you know a little bit what this is about. I'll try to explain it in a couple of minutes, a topic that's very complex, because it will also show us the reason why people are in pain management and what are the new trends in pain management. And you'll see it in a minute what I'm trying to say. So when we talk about opioids, we're talking about, let me go back here, medications such as Norco, Vicodin, Tramadol, and OxyContin. And I'm sure you've interpreted these names of medications throughout the years. So like I said at the beginning of my presentation, for years, a lot of doctors believed that patients were suffering unnecessarily. People with chronic severe pain didn't get the medications they needed to relieve their pain. And there was a particular pharmaceutical company that created a powerful narcotic called OxyContin. It's listed here in this slide. And this medication was definitely an amazing medication to treat pain. It was a narcotic or an opioid. And and it was marketed in a way, it was a time release medication, meaning that you could take the medication and the effects of the medication would be gradually delivered to the body. That way the patient would not, the risk of addiction will be less. Addiction with medication happens when the patient takes a medication and gets what we call a high. But if the medication is time released, that high should not happen. And this is how these medication, in particular OxyContin, oxycodone, was marketed very aggressively by pharmaceutical companies. And it was certainly a great medication for the treatment of pain, but it was very powerful, so it had to be prescribed carefully. However, and it was prescribed millions of times. So I won't go into detail about how many medications. So this medication was prescribed, but millions and millions. What happened is that people abused this medication. They would take more medication than they needed. And worst of all, people discovered that they could crush this OxyContin medication. They could crush it, and then they could smoke it or inhale it. And that way, the effects of the medication will be quicker, would go straight to your brain, and then the time released aspect of the medication was gone, and people would get a high, and that's how people became addicted to this opioid, in particular this one. By the time doctors realized they were having a problem, because the patients, let's say the doctor would have prescribed a narcotic or an opioid for 30 days, but the patient by day 20 or 15 would be back at the office asking for more medication. The doctors realized they had a problem. They had patients who were showing signs of addiction, dependency and addiction to these medications, but it was too late. There were a lot of people who were addicted to these medications. And what the medical profession did in pain management is to ask the pharmaceuticals to manufacture the same medication in such a way that could not be crushed. So yes, the pharmaceutical created an uncrushable OxyContin, but by then it was too late. And by then, the doctors were very reluctant to prescribe this medication. And by then, what some people did, unfortunately, was to find the medication, quote unquote, somewhere else. And what I mean by that is to go to the street market or black market and buy heroin. And heroin is an opioid as well. It's the same family. And whereas if you wanted to buy a pill of OxyContin in the street, which you could, because I tried it to do it, it would cost you $70 a pill. A heroin, a little bag of heroin would cost you $25, $30. And people decided to take heroin. And maybe if you've been following news, you've seen there's been a huge spike of heroin use and overdoses in the past couple of years. And this is the story. This is the story because a lot of these people had become addicted to opioids. Why am I telling you all this story? I'm telling you this story because a couple of years ago, or 3 years ago already, the CDC, the Centers for Disease Control and Prevention, issued these guidelines for prescribing opioids for chronic pain. And basically, the idea is that non-pharmacological therapy treatments are preferred. So they tell the doctors, don't prescribe medication if possible. Try conservative treatment and only prescribe opioids if the benefits of that medication outweighs the other treatment. And that's why probably you've seen this trend in pain management of very frustrated and angry patients who want those medications and they cannot get them, and nobody has explained really well the reason why. And patients see that there's no advancement in their recovery and that their visits might be a waste of time. So sometimes these appointments are kind of frustrating, to be honest with you, because patients are frustrated, they're in pain, and they feel that they're not getting the treatment they should be getting. And going back to the opioid crisis, what I've noticed in some pain clinics that I go to interpret, and they're called pain management clinics. Now they're changing their names and their marketing materials say wellness center, comprehensive pain and wellness center. So pain management is becoming a wellness center. And what does that mean? And also, these are pictures I took of two brochures at a pain management clinic I go often, where, as you can read, and maybe you can read it, it says, focus on opiate transition program. So pain management clinics are becoming like rehab centers for people who took opioids that were prescribed by them at those clinics, and now they're trying to transition or ease out of the strong medication or dependency into other kind of treatments that hopefully are not so pharmacological dependent. So perhaps you see things like group therapy, yoga, meditation, nutrition, or you might see new trends such as I've seen Graston technique, where on top of physical therapy, the practitioner uses these stainless steel instruments that have different shapes to resolve or help with a scar tissue. Another new trend I've seen is the virtual reality, Graston techniques, the laser therapy, and the idea of a wellness center that I'll expand on in a minute. And I just want to go over some minimally invasive treatments, injections, pumps, stimulators, and others. Just a couple of things about injections. These are very typical injections that you might have to interpret as some of these appointments, like lumbar epidural steroid injections to reduce inflammation and pain due to disc herniation. And by the way, all these medical terminology that you see on the slides, it's in a couple of handouts that you can receive or download. And I have one with all the terms in English. There's one with some glossary in English into Spanish, and also another one from English into Chinese for you to have. You probably have heard about facet joint injections, where the provider injects a small amount of anesthetic in the facet joints to numb the pain. Trigger point injections, those are done in the doctor's offices. They don't have to go to a clinic to do this. And then also for people with disc herniation or cervical problems, the stellate ganglion block, it's also an injection of medication in the sympathetic nerves of the neck for people who have problems with their cervical spine and they have symptoms radiating down their arms. And here are some new trends that I've seen. I don't know if you guys have interpreted at injection appointments where the patient is actually injected platelet-rich plasma. So basically, they take their own blood, they spin it, and they concentrate platelets, and they re-inject it. Usually, they do that on knees and also I've seen it on wrists. So I've seen this as a new trend, and I interpret a few appointments of what's called PRP injections. And another one that I've seen in the last couple of years is what's called visco shots, where basically they use this hyaluronic acid, which is a substance that our body connecting tissue creates naturally that helps joints to articulate well. And it's a gel-like substance, and usually the patients receive 1 to 5 injections. These are people, again, with moderate to severe chronic pain. Usually these injections are given in the knee. And a couple of more treatments, minimally invasive treatments, discogram, which is what we call a diagnostic study. So basically, they insert a needle in the region of the disc and they apply pressure. They use a contrast dye and they ask the patient is sedated, but the patient can speak, and they ask the patient, do you feel pain? No, the idea is to discover the source of pain. Once they discover what the source of pain is, the doctor knows what the next step should be. Maybe you've interpreted neurotomy appointments where basically they destroy the function of a nerve by cutting or burning the root of the nerve. The nerves can grow back, and because they believe that that will block the pain impulses to the spinal cord. And finally, I used to interpret a couple of appointments for people who would be implanted a spinal cord stimulator. It's been a while since I've done these kinds of appointments. Again, I think that these are not offered as much as they used to be offered in the past. So again, the new trends are going into more natural and more effective kinds of treatments and least invasive. And the spinal cord stimulator is basically a device that's placed under the skin and delivers electrical pulses to the spinal cord. Sometimes patients, before they go to these, they undergo this procedure, they have to see a psychologist. And also, I remember interpreting in the past for people who've been implanted with what's called an intrathecal pump, with people with chronic severe pain. They've tried everything, and nothing works. And basically, the pump delivers a small amount of medication, and the patient controls that. So, and finally, I want to close with what we call the functional restoration programs. Maybe some of you have interpreted in this kind of programs where the patient attends for 6 to 8 weeks, goes every day, usually Monday through Thursday, Monday through Friday, spends several hours a day at the doctor's facility. The idea of the functional restoration program and to restore the patient's level of activity. So the patient, by being more physically active, by being more functional, his or her emotional state improves as well, and their quality of life. A very important thing for us interpreters is that if you're offered these kinds of appointments, of functional restoration programs, you need to ask how long this appointment will be. They're usually all day long, so you need to be aware of that and ask for a minimum payment of hours if that's the case. Sometimes it's just one person in the morning for 3 hours, another person in the afternoon, but just make sure every time you hear functional restoration program, ask, is this going to be an all-day program? And then, negotiate your rates accordingly. And also ask them if they're going to have some kind of simultaneous equipment, because you will have to interpret simultaneously because the patient is in a class basically or in group therapy, and you don't want to be whispering in the patient's ears all day long. And just you should demand and request this kind of equipment, which means that also if you always have to get to the appointments early, in these cases you should arrive a little earlier just to test the equipment, make sure it works, etc. And also, these kind of programs have all kinds of expect to interpret for doctors, psychiatrists, psychologists, nutritionists, etc. Sometimes patients are in acupuncture, you just sit there, do nothing. Sometimes they just in a class, etc. And sometimes they see a psychologist to talk about different kinds of problems due to chronic pain, such as depression, stress, anger, sleeping problems. And the idea of this program also is to reduce the dependency on medication. So this is all I have. And here's my contact information. You're more than welcome to email me if you have any questions about pain management or specific things. And I will be happy to answer any questions that you may have. So I'm open to any questions or comments.
Okay, thank you so much, Judith. That was a wonderful presentation, always very informative and useful information. We do have a couple of questions about the topic.
Sure.
One in particular around interpreting practices. So my question is not about pain, but general interpretation practices. Suppose a health practitioner is conveying an unfortunate message like a death or serious illness, and their way of doing it does not seem sensitive to the patient. Should you interpret the message as it is or package your words in a more sensitive manner?
Okay, so that's a great question. And this has to do more for palliative care or end of life. And it's interesting. I'm glad you're asking me that question because 3 weeks ago I attended the ATA conference and I attended a great presentation of end of life care in pediatrics. So imagine this is for children who are very ill or dying, and how you convey those messages and how delicate and difficult that is. And the presenter had these excellent points, and basically it's hard to give a specific answer, but the idea is that we interpreters always interpret the message the way we receive it. We don't embellish, we don't add, we don't change it, right? So this is what I always do. And then, but if the patient, I think that's what you ask, you feel the patient is confused and doesn't understand or didn't get the message, there's two things you can do. Hopefully the provider will notice that and provide an additional explanation. But we can always, and especially in these situations of end of life, etc., we can always can step in, and that how to do it in a professional manner and say, speaking as the interpreter, I believe there might be some confusion, or can I please ask and then you can ask the patient, do you have any questions? Did you understand? Do you have any comments or questions? Just to double check, because maybe sometimes we assume the patients didn't understand something, but they did. So you always don't assume anything. Just double check with the patient, be transparent, and then my hope is that in these delicate situations that the people you're working with, providers, doctors, etc., are sensitive and know how to convey these messages. But again, my first step is I interpret the message the way it was delivered, and then we can always step in and even advocate in depending on the specific situation. It's hard to say without more context.
Right, that makes total sense. I always know that it's, one of my conundrums always as an interpreter is not wanting to get too emotionally involved, even though you're human. It's hard not to feel for people. But yeah, it's always like Judith said, it's always best to remain impartial as best to your ability. So everybody in the audience, we're going to be closing the presentation unless you have any other questions you want to write in the chat window. I'll give you guys a couple minutes, but other than that, we're gonna thank Judith for her time and for sharing her knowledge, and Wish everyone a great week. Those of you who are celebrating Thanksgiving, happy
Yes.
Thanksgiving. And those of you who are not, just have a wonderful week. And some people are asking here if it's possible to
Mhm.
get the PowerPoint file. I understand if you don't want to send that out, but we will send out a recording. So
Oh, the PowerPoint. Yeah, so yeah, we can do, I can certainly, because the PowerPoint has a lot of pictures and images. This is a large document.
large file.
It's a large
Yeah.
file, yeah. So, but I can do is to, sometimes what I do, and I ask this from other presenters, I can reduce it or eliminate slides that are just pictures, images not relevant. So I can certainly share that. But like I said, if I'm not mistaken, one of the handouts that everybody can download is actually all the medical terminology that appear on these slides. It's
Mhm.
there. So all the
Right.
relevant, there's a lot of slides about the pain scale. You don't need that, you know those. But all the relevant medical terminology that you would think, oh, I'm not sure how to say that in Spanish, it's there in the handout. And
Okay. Great.
yeah,
Yeah.
but I can share, I can definitely send you, Caroline, a reduce file where I can, I can weed out all the slides that are not that important, and you can share it with with
Okay.
everybody.
Thank
Yeah,
you.
sure.
Thank you so much. So yeah, we will be people asking about the downloads and everything. We'll be sending you those via email after the webinar.
Okay.
So stay tuned for that. And thank you again, Judith, for joining us. Everybody's saying thank you very much on the chat. So and they loved your presentation. So
Oh, thank
thank
you.
you again.
Thank you, guys.
All
Happy
right.
holidays. Don't need too
You
much.
too.
Okay,
Bye.
bye. Bye. Thanks.